as I just mentioned, to correct that ulcer and remove the stitches to be biopsied. Then we can apply two things now: ulcer healing modality that we're going to discuss, and compression. For the compression therapy and ulcer healing modality, as I will show now, we have evidence-based medicine that we can apply vac therapy, negative pressure wound therapy. That would benefit us in several factors, as I will mention in the coming few slides. Again, another ulcer. It's a big ulcer. It's an lymphedema and a great swelling there, as you can see. This is long-standing ulcer with venous aspects. It was nasty before, then we started to debride that ulcer, and then we applied the vac therapy and the modalities that we're going to discuss afterwards. That's how the ulcer will close. Then the marvelous effect of your elegant maneuvers for the manual lymph drainage and lymphopressment bandaging. And for this case, I would thank my colleague, Dr. Eva, for the marvelous results that we achieved after clearance of the ulcer, then clearance of the lymphedema. Again, you might have the ulcer, but not an underlying great saphenous vein, just only a part of the distal part of the great saphenous vein. That duplex is a courtesy of Dr. Wasila. It's a unique duplex that we all know that is unmatched elsewhere. The issue is to find the lesion. The lesion here wouldn't allow radiofrequency or laser or ablation because it's of the close proximity of the nerve. So we're going to apply a foam in a reversed form to heal the ulcer, among the other modalities that I'm going to mention immediately now. Here's the reversed foam. We apply, as you can see, the wire and the cheese, and then we can keep the introducer out and keep the cheese in and reintroduce the introducer in another part above, as shown in the other video. Here we are applying dual axis, and then the foam sclerotherapy, duplex guided, as you can see, the duplex machine aside. By this, we achieve the fullness of the segment of the vein that have been refluxing and causing the ulcer to be resilient and persistent. So after this, we need to apply an ulcer compression. If you apply either the bandaging or the tubular stockings, you will have a very soaked dressing. So we can apply a circade for the time, and this will adjust the pressure from 35 to 40, and we can achieve a good compression, and we can dress the wound underneath it. Talking about the dressing and the wound healing, how to achieve such an ulcer to heal such an entity? Simply, the answer is the vacuum. If you apply the vacuum, you are going to withdraw out the lymph from the ulcer. So there is no lympharia, there is no further irritation, there is no further widening of the ulcer itself. Moreover, it causes proximity of the wound itself. It initiates revascularization, bearing in mind that the vessels are free and the vessels are enough, not ischemic. Then the vessels in the vicinity of the ulcer itself, the capillaries, would reach more blood to the ulcer, and by this the vac would play an integral role. This idea first started when I first had been working around 20 years ago in one of the renowned centers of lymphedema, where this case was referred to me. That case was a very resilient ulcer, and the patient was pouring lymph. And you can see the hump and the huge lymphedema seen there. That was my first time to apply 20 years ago the vacuum therapy, and I had definitely never read before upon this. Later on it was published, and I published a publication of myself. But see how can we get diminution of the girth of the ulcer of the leg itself, withdrawing the lymph out, not compressing it back inside the lymphatics by the manual lymph drainage. We just extrapolate or withdraw or suck the lymph out of the foot, out of the limb. If we suck the lymph out, we would achieve diminution of the girth, better perfusion of the ulcer itself, and you can see along the edges the newly forming granulation skin and fresh granulation tissue.
دي الحالة اشتغلها كرولوزورس.
Do we extrapolate much lymphatics from the lymphoria? Do we suck much lymphatic fluid? That will answer the question. See how much lymphatics. It's 500 canister full of lymphaowie, fully full of lymph fluid, you play a very marvelous role to push it back into the lymphatics. But this device helps you at the start to pull it out, then you maintain this by pushing out the residual amount that wouldn't be pulled out. And moreover, you can compare the ulcer's bed itself, how nasty it is in the above picture, and the picture below, how much perfused and how much vivid it looks like, and going to its way or direction to healing. That was the paper published with the two cases, and another cases with diabetic foot. I mean, the role of VAC in lymphedema is very here to stay. There's publications on this. This is my own and others are valid. What about the dressing of the ulcer? This would be my last slide, or was the last slide. If we want to choose the perfect dressing that we would all agree upon, various meta-analysis, none of them, I repeat, have shown certainty this particular dressing to be applied. And the only one that mentioned a result was for the silver impregnated dressings that will not be more than 28 days or 4 weeks to be applied. This was the only paper written, to my knowledge, that have mentioned benefit, but not certainty, not recommended, not present in guidelines. So, how could we think of an ulcer healing dressing? First, one should ask me, when you apply the VAC, what about the infection? So, this dressing solves the issue of the infection. It's the active coat, it's porous. It has pores to allow the lymphatics to be withdrawn from inside, and it has a heavy burden silver to clean the wound. What about the vivid or the vitality of the ulcer granulation tissue? We can allow oxygen, and you have all heard about hyperbaric oxygen, topical tissue cell oxygen. Here there's a material that's the granulox that allows oxygen extraction from air and impregnation of the wound by that oxygen, but we have to apply it and leave it in air for 10 minutes to absorb the oxygen from the air to the vicinity of the ulcer itself. Of the capillaries and the veins in the vicinity of the ulcer, and even after you have done your role with the vacuum extrapolation of the lympharia, you can apply a secondary dressing like any dressing with silver, preferably one that allows exchange of gases, like Miplex silver, for example. My last slide. Are there other, but this fever, not fever, modalities of treatment? Yes. In this context, we don't use therapeutic ultrasound. In this context, we don't go for transdermal cutaneous oxygen therapy, hyperbaric oxygen therapy. They have not proven efficacy in any of the guidelines. Autologous platelets-rich plasma or skin grafting. Skin grafting has the same issue. It's if we apply the graft, we have a lympharia underneath. It won't take, and it will always keep on being moist until it is completely rejected. Thank you very much for your precious time.